All right, it's 5, so I think we'll get started, and the other people can pop on as they come in here. So, um, I am recording, so you guys know that. So tonight we're gonna be doing chapters 11, 12, and 13, finishing up primary assessment, secondary assessment, history taking, reassessment, and then I'll show you some the flyers or the handouts that I gave you guys, the OPQRT sample, secondary assessment questions. Some of that I'll kind of talk about, so you guys have an idea of why I did that. And then we'll move into the last one, which is communication and documentation. So let's see, I'm going to share my screen here and we will go with chapter 11 because that's what we're going to start with tonight. All right, downsize us into the corner, make this bigger so you can see it. All right, so chapter 11, finishing up patient assessment. So we'll talk about history and vital signs. So topics of this chapter is patient history and vital signs, just like the title is. So a little intro to this. Once we do our scene size up, so PPE, scene safe, mechanism of injury, nature of illness, additional resources, taking control of that C-spine, and then we get into our primary assessment. We kind of talked about all of that. We would want to then complete some additional information to make sure we kind of know what's going on with our patient and kind of a treatment plan for them. So talking to the patient, finding out why we were called, is kind of the reason we were called. It's going to end up being their chief complaint. Finding out about the patient's medical history, getting some vital signs from them, like their blood pressure, their pulse, respiratory rate, their O2 sat, simple things like that. And then completing an examination to get a better picture of kind of what's going on with our patient. So we'll talk a little bit about that. So patient history, when it gets down to chief complaint, this is the most important question we can ask somebody is what's wrong. So we get through our primary assessment, and that's kind of when you get to the AVPU stage of that. It's when you're walking up to your patient saying, "Hey, my name's Alyssa. I'm here with, this service. What's going on? What's wrong?" The patient's answer of what is wrong, the question that we ask, is the reason that they called or their what's known as their chief complaint. So if the patient is a child or if they're unresponsive, we kind of have to obtain the chief complaint from maybe a family member or bystanders, or maybe their chief complaint is that they are unresponsive and we can't get any information from them. So the patient tells you or complains, their complaint is likely to be what's called a symptom. A symptom is told to you, can't be observed or measured. So a symptom is like I'm having pain, something we can't see. A sign is something objective, some finding that we can see. So let's say if they have pain in their arm, we see the swelling and the bruising. That's a sign. So symptom is something they're feeling and can tell us, where a sign is something that we can observe and see for ourselves. Like somebody is nauseated, that's a symptom. When they vomit, that's a sign. We can look for clues. If no one can provide the chief complaint, we need to look around their house for clues to find out what's going on with the patient. We can look for medical jewelry, medications that we might see at the scene, if there's drug paraphernalia, stuff like that, just to kind of figure out what's going on. We want to identify the nature of illness. For medical patients, typically it's going to be an illness. And then trauma patients, it's typically going to be what the mechanism of injury is, so how they got hurt. So when it comes to identifying the nature of illness for medical patients, what events kind of led up to us being called? Did the problem develop suddenly, or was it over a period of time, so more chronic? Has the problem gotten worse? And that's why they called. For examining the mechanism of injury, this is typically, again, for trauma patients. This is going to give us an idea of what's wrong with the patient, how they got hurt, what happened for them to call us. Some things that we can use for this are what's called sample history, and I'll show you why these are important when I swing back to the National Registry sheets that I gave you guys last week. So the sample mnemonic, this is going to help remember key components on trying to get a thorough history on somebody. So medical versus trauma, and we'll talk about that in the next chapter, doing reassessments and secondary assessments, but trauma is a lot easier, right? Because you can see it and fix it. Leg is broken, we can splint that. Medical is just like asking a ton of questions, trying to figure out what's wrong with them. So we use these mnemonics. So sample being the first one. S is for signs and symptoms. This includes the patient's chief complaint. A is for allergies. So asking about any allergies to drugs, foods, other items. M is for medications. This is, what medications have they taken? What medications are they on? Have they taken any before we've gotten there? P is past medical history. This includes the past medical problems. So if they're having chest pain, have they had a heart attack in the past? Have they had stents put in? So a past medical history that's also pertinent to what's going on now. L is last oral intake. So recording the last time the patient had anything to eat or drink and what was it. And then E is events leading up to the situation. Specific information that we get from them can eliminate some of the possibilities that we're thinking of our index of suspicion. So, example, they give if a patient complains of chest pain and has recently fallen on their chest, maybe we can rule out a heart attack. Maybe they have a broken rib or something like that. So, what events led up to us being called? When we get to medical side of stuff, I'll be talking about another mnemonic called OPQRST. But vital signs. So vital sign wise, we use our senses, taste, smell, probably not taste, smell, sight. So we're look, listening, and feeling with this stuff. Hopefully you're not tasting anything, but sometimes you get that in your mouth. Sphygmomanometer. This is just a blood pressure cuff, just a big fancy word for a blood pressure cuff. And pen lights. These are some tools that we can use for taking vital signs. Respirations. So when we're assessing respiration, so people breathing, right? Inhalation, exhalation. So when we're assessing respirations, we want to know how many times the patient breathes in 1 minute. We call this breaths per minute. We're going to calculate this by counting the patient's breaths for 30 seconds, and then we multiply it by 2. So remember, the typical adult respiratory rate is between 12 and 20. So they should be kind of in that ballpark. If they're breathing a little bit slower than that or breathing faster than that, there might be something else going on. So we want to watch the patient's chest rise and fall, but we're not going to tell the patient that we're doing this because they can kind of change their breathing as we do this. So they may unconsciously do that, change their breathing pattern. What we're looking for is the rate. We want to make sure that it's between kind of around that 12 to 20, or child 15 to 30, or infant 30 to 60. The quality, what's their respiratory effort? So assessing whether or not respirations, if they're labored, fatigued, shallow, they're not getting that good chest rise and fall, means something maybe is wrong with their chest. Are they gasping, having that agonal breathing? So what's the quality of it? And then sounds, we want to observe and listen for abnormal sounds like stridors, kind of a high-pitched breathing. Gurgling would be like vomit or blood that we'd have to suction out. Wheezing, maybe they have asthma, things that we can hear. So if breathing is inadequate, we need to be pretty aggressive when it comes to airway and take immediate action to correct that, putting them on oxygen, what's their O2 sat level, that kind of thing. How do they look? So respirations. Pulse is another thing we can measure. So when the heart contracts, it sends a wave of blood through the arteries that can be palpated at different points that are close to the surface of the skin. This palpable wave of blood is called your pulse. We document this in beats per minute. So we're going to do the same thing. We're going to count to 30 and multiply it by 2. And we can assess for pulse for the rate and the quality and regularity. So assessing for the rate in beats per minute. So typical adult rate is like 60 to 100, somewhere in there. The quality, can you really feel it? Is it strong and like bounding, or can you barely feel it? Is it weak in that area? And then checking for regularity. Is it regular? So as you're feeling those 30 seconds, sometimes we have to do 60 seconds, but as we're feeling for it, is it a regular pace going through, or is it skipping every once in a while? Is it irregular? So assessing the pulse, there's a few common places that we do this. For conscious patients, people who are alert, orientated, anybody that's not unresponsive or unconscious, we try to assess the pulse at the radial artery at the wrist. So right above your thumb, feeling right there, that's going to be your radial artery, pushing down on that, your radius. For unconscious patients, we assess the pulse at the carotid artery, the one that's in the neck. So finding the trachea going to one side and pushing in, that's where you're going to find your carotid artery. So anybody that's responsive, adult and child, we go right to the radial or the wrist artery. And anybody that's unresponsive or unconscious, we go for child and adult, we go to the carotid artery. It changes a little bit for infants. Infants, we're going to use the brachial artery. That's the one that's kind of by their armpit and just down from there. If you feel in kind of by their bicep, you should feel the brachial artery right there. That's what we're going to assess for in infants. We can do that for people like adults as well. And then the other option as a central pulse, just like the carotid artery, is the femoral artery. That's the one that you're going to find in the vein or in the groin area. So if you push down kind of in the middle of your groin, you should be able to feel that femoral pulse right in there. The carotid and femoral are going to be the two that are the central ones that are going to last longer than the ones that are out further, the distal pulses, which are your radial by your wrist, and then our pedal in our foot. We're going to assess the skin. We're going to assess the skin for color, temperature, condition, and capillary refill. So looking at skin, normal skins, pink, palms of the soles of dark skinned people. They can be pale. Pale skin is a sign of poor blood flow and may indicate poor perfusion, or what's known as hypoperfusion, or also known as shock. Cyanosis and is that bluish skin. So the lips and the fingernail beds usually start first with that. Redness or flushing, this is usually caused by a dilation of blood vessels, and a yellowish skin is typically caused by liver diseases. So checking their color, checking their temperature, checking the condition of their skin, what does it look like, and then capillary refill. This is where we're going to push down. Usually this is accurate in children under 6, but we do it on adults as well. So we can squeeze the skin and look for blanching. Then we're going to count. Usually anything less than 2 seconds is normal. That color will come back. So once we push down on the skin, we pull back up, it'll turn white. We pull back up, it should turn red. We can do this in fingernails of adults. So if you just take your finger and you squeeze your other one of your fingernails with your other hand, you'll see it white and come back to pink. That in less than 2 seconds, that's normal. If it takes longer than that, it's a delayed cap refill. So something's going on with their circulation. So color, pale skin, cyanosis, redness, yellowish skin. What color is it? Temperature, skin is normally 98.6 degrees Fahrenheit. So we're going to assess the skin quickly. Are they cool? They could be in shock. Are they hot? Might be a fever or heat stroke. So pale, cool, clammy. What's the temperature of them? What's their skin? And then condition, skin is normally dry. Moist skin can mean shock or distress. And then our capillary refill time. So these are different things we can look at with the skin. Blood pressure, and I know Jules is going to practice this with some of you guys, and I can practice with the rest of you. But when the heart contracts, it exerts a pressure inside the arteries of the body. That pressure forces blood to the cells. There's 2 stages of the pressure inside of our arteries, and that's where we get our top number and our bottom number. So the top number is our systolic pressure, is the presence of the contraction of the heart. So it's a little bit more forceful. Diastolic pressure is the pressure in the arteries when the heart starts to refill, so it's not going to be as high. So when we're measuring blood pressures, the cuff should be the correct size. There's a few different sizes of cuffs. The width of the cuff should cover roughly 2/3 of the length of the upper arm and should be large enough to Velcro firmly when it's closed. Again, we use the sphygmomanometer for this. That's also known as the blood pressure cuff. So systolic, that's our top number. Diastolic, that's our bottom number. So this would be like the 120/80. Normal blood pressures vary among patients. So normal blood pressure is not a very accurate statement when we're dealing with adults. So everybody has a little bit different blood pressure. So typically for children, 90 plus 2 times the patient's age in years. So say the patient's 10, it would be 110 would be like the top number for systolic. And then the bottom number, the diastolic number, should be between 50 and 80. When we're getting into adults, this is where people have blood pressure problems or hypertension, high blood pressure. They have low blood pressure. So what's normal for one person is not normal for another person. A lot of times older folks will know what their typical blood pressure is, so we can ask them that as well, and see kind of where it falls in when we take it. Um, but adults usually is 100 plus the patient's age and years up to 150. So 150 as the top number is kind of what we're looking for, is kind of like a high. And then the bottom number, the diastolic number, between 65 and 90. So that's why I see people say like 120 over 80 is a pretty good blood pressure. Points of concern for adult patients are when the pressure is less than 90 or greater than 180 systolically. So if it's getting up there above 180 or above 90 diastolically, then we need to start worrying a little bit. And if it's below 90 on that top level, we start worrying a little bit as well. So somewhere in that 90 to 180 top number is okay. So we can take blood pressures by two different ways. There's blood pressure by auscultation and there's blood pressure by palpation. So blood pressure by auscultation, this is how we're gonna typically do it if you have a stethoscope and a blood pressure cuff. So we're gonna apply an appropriate size blood pressure cuff to the patient's arm. We're gonna find the brachial artery, place the bell of our stethoscope over it, which is usually somewhere right in the area of the inside of the elbow, towards the inside. You're gonna hear it. We're gonna inflate the cuff. As we inflate it, we're gonna lose sound. A lot of times, what I tell my students is, I put the blood pressure cuff on. I'm gonna inflate it to like 200, and then I'm gonna start deflating the blood pressure cuff. And as you deflate it, that's when you're gonna get your reading. So as we deflate the cuff slowly, we're gonna listen. We're gonna hear nothing, and then we're gonna hear a heartbeat, and that's going to be our top number. So it should be between that 90 and 180, hopefully. So we're going to hear it, and we're going to hear it, and then eventually, as we work our cuff down, it's going to get kind of weaker and weaker, and then as we don't hear it, that's going to be our bottom number, roughly right between 65 and 90, hopefully somewhere. So as we continue to deflate that cuff, that's what we're listening for. So once we inflate the cuff all the way up, I usually do to like 200, then I'll slowly deflate the cuff down. And as we deflate the cuff down, you're going to hear the pulse. You're going to hear the heart rate or heartbeat. That's your top number. You're going to hear it. You're going to hear it. You're going to hear it. And it's going to slowly fade. When you stop hearing it, that's going to be your bottom number. And these are things that we'll need to practice too. If you guys aren't familiar with these, it's easier just to kind of do it. So auscultating the blood pressure, again, that is using your stethoscope, listening to the brachial artery right here, and then putting in a properly sized cuff and watching your sphygmomanometer, your little graph here. So this usually pumps up, can go to 300. I usually pump this up to 2, then I'll slowly deflate it. And once you hear that first heartbeat, that's your top number, and you'll hear it, you'll hear it, you'll hear it, you'll hear it. When you don't hear it, that's your bottom number. You can just, unflate the rest of the cuff for them. So that's by auscultation. If you are in a noisy area, or maybe you don't have a stethoscope with you, you can also do it by palpation. So doing it by palpation, what you're going to do is very similar. You're going to apply the appropriate size cuff to the arm. We're going to find the radial pulse, again, which is actually this one down in here by the thumb side. We're going to find that radial pulse, and we're going to palpate it while we inflate the cuff. So we're going to feel the pulse. We're going to pump up the cuff until we don't feel the pulse. Then we're going to inflate it 30 more. Once we start deflating the cuff very slowly, we're still feeling for the pulse the whole time. When we feel the pulse return, we're going to record that as our top number, but then we're going to feel it the rest of the time, so we're not going to have a bottom number on it. So we do stuff like we pump it all the way up, we lose the pulse, pump it up a little bit more, we start to slowly deflate it. Then when we feel that first pulse, that's our top number. We're going to do that over P, which means it's by palp. So we're not going to have a bottom number, but at least we have a top number to go off of. If we're in an environment that is just too loud, or we don't have a stethoscope, something like that, getting a top number, at least we have that kind of detailed in there. So this one, again, you're going to pump this cuff up. You're going to feel for a radial artery, feel for a pulse here, and then you're going to inflate this cuff until you don't feel a pulse here. Inflate it 30 more points. and then you're going to slowly deflate it. And once you start deflating it, once you feel your first pulse here, that's your top number over P. So that's doing it by palpation, which is a good option for some people. Pulse oximetry. So this is a device that measures the amount of oxygen carried on the red blood cells, or what's also known as your hemoglobin in your blood. The pulse oximetry can be an accurate way to assess the level of oxygenation in your patient and display trends of improvement or decline. Normal reading, usually between 95 and 100%. Readings below 95% indicate hypoxia. That's changed a little bit in most places to 94%, but it's a good ballpark. Most pulse oximeters use a probe or clamp-like device that surround a finger, like as in here, or it can attach to an earlobe as well. And they transmit an infrared light through the tissues. Measurements can be affected by nail polish, cold temperatures, or poor circulation. So if you're not getting a good reading, we might have to warm their hands up. These can only determine saturation of the hemoglobin. It can't determine what it's saturated with. So like people with carbon monoxide poisoning can have 100% reading on there, which is probably not correct, but it's binding with something it just doesn't know. So these are tools that we use to get a perspective of how our patients are doing, but also treating the signs and symptoms your patients are showing you too. How's their skin look? That's why we do all of this kind of together. So this top number that's in red, that would be their pulse oximetry is in a percent. So 95%, right? We're in that ballpark of it's being okay. The bottom number that you usually see on these is your pulse rate. So their pulse rate is 59, which then you could then match up with taking it manually. The other thing that we check are pupils. Normal pupils react to light by constricting when light is present and dilating in low light conditions. So these predictable reactions can provide information about kind of what's going on with people's central nervous system and the health of the brain. So we can use a pen light. We can shine a pen light in the patient's pupil and assess for constriction. The pupil should kind of constrict and then dilate back out. We say what's called PEARL, pupils equal and reactive to light. They should both react equal on both sides. Abnormal findings are no activity, reactivity at all, or significant problems with the brain that can indicate. It can be sluggish to react, maybe a stroke patient, something like that. Maybe they're unequal. One's bigger than the other, so they're having some kind of neurological event going on. All right, so that's basic history and vital signs. So for this, which of the following is considered a symptom? So again, a symptom is something that they're feeling or they're telling you, right? So patient tells you they're having chest pain, that would be a symptom. Patient's blood pressure, 120/80, that would be a sign because we can see that. We note severe bleeding, we can see bleeding. Observing patient stop breathing, again, we can see that. So this one would be a symptom. They're telling you they're having chest pain. We can see the signs of it right here. S and sample history. So you guys are gonna have to make flashcards. So sample, OPQRST, AVPU, I'm throwing a bunch of stuff out at you. But sample, the S, signs and symptoms. Our A in sample, allergies, right? M would be medications. Our P would be past pertinent history, past medical history. L would be last oral intake. Sometimes I say ins and outs came out as well. And then E is events leading up to that situation. Why did they call us? Okay, so that one is chapter 11. Any questions on that one? Feeling good? Okay. Feeling good. Sweet. Sounds good, Kevin. All right, let's get into chapter 12. I'll share my screen again with you. So chapter 12 is our secondary assessment. So this one is going to talk about general principles of assessment, trauma versus medical assessment, because they are different when we get to that. Vital signs, we're going to revisit those again, and then reassessment. So intro to this. So secondary assessments, when we do these, we try to make them kind of as systematic as we can. Beginning with our scene size up, primary assessment, working into that secondary assessment and reassessment, which the sheets that I gave you for medical and trauma kind of flow you through that in a proper order. So the primary assessment, again, centers around identifying those life threats that must be immediately addressed. They don't have an airway. We need to suction. They have a bleed that's going to bleed out. Then we have to put a tourniquet on. The secondary assessment is a systematic assessment to identify anything else that might be wrong with our patients. So we're going to use the time before EMS arrives to complete our secondary assessment, or at least start it and go from there. It's critical in determining the care that we provide, as well as gathering vital signs, other valuable information that we can give to EMS once they arrive on scene as well. So general principles of assessment. The secondary assessment is, again, that systematic process in which we're going to obtain a history, perform a hands-on assessment of the patient, get our vital signs. We're not going to begin the secondary assessment until our primary assessment is complete. So we have airway, we have breathing, we have circulation, we have additional resources en route. We have all of that done before we start this. This isn't a priority, but we want to start this before EMS arrives if we can. The primary assessment is the most important thing, and that's where we're going to identify and correct those life threats in patients. And sometimes if we're doing CPR on somebody, we might not get into secondary assessment at all because we're still doing the primary assessment, maintaining their airway and doing compressions on them. So principles of assessment, we can look, listen, and feel essentially. So observing is looking, auscultation, that's getting your stethoscope out, that's listening. Palpation is feeling. So we can look, listen, and feel. So some methods of assessment. So once we get into observation, just simply looking at the patient is going to often provide us clues as to what's wrong with the patient. Are they clutching their chest? Do they just look really sick? Are they leaning forward in that tripod position so they're having trouble breathing? So we can just tell by looking at people if they're sick or not sometimes. Auscultation, you may hear the patient wheezing as we approach. You can use a stethoscope to determine if air is moving in and out of their lungs, checking lung sounds, that kind of thing. So kind of listening to what's going on with our patient. Are we hearing any sounds that we shouldn't be hearing? And then palpation, we want to palpate easily at first, then apply more pressure if needed to an area to fully assess it. We're going to perform this portion of the exam systematically from head to toe, which we'll talk about in a little bit here. And distracting injury, that's one that can be obvious or painful, but not necessarily the most serious. So they have a really cool fractured leg and it's bent in an angle, but they don't have an airway. That's called a distracting injury. We're going to use the mnemonic DOTS. So DOTS is going to help us remember to look for deformities, open injuries, tenderness, and swelling. So when we're doing this head to toe on people, especially for trauma patients, we do our secondary head to toe. This is what we're looking for. We're using that mnemonic DOTS. Looking for any deformities, any open injuries, any tenderness, any swelling in the areas that we're doing that head to toe. So different patients. While the patient assessment process is the same for each patient, the order and priority we give each step is kind of based on what type of patient we have. So the different types of patients kind of are into 4 general categories. So we have seriously ill patients or seriously injured patients. We have non-seriously ill or injured patients. We have medical. So we're going to talk about these shortly. And we have trauma patients. So what kind of patient do you have? So you walk into a client's home and they're laying on the floor. Is it a trauma or is it a medical? Or did they have a medical event that then led them to fall and hit their head on something? So it's kind of both medical and trauma. So just trying to figure out what initially is going on with our patients. When we're assessing these patients, seriously ill or injured, these patients may have an altered mental status, severe pain, problems associated with their airway, breathing, circulation. We may never get to the secondary assessment, like I said, because we're managing those life threats first. We're opening their airway, we're giving them breaths, we're doing CPR. All of that is primary assessment stuff. Non-seriously ill or injured, these patients do not have a life threat typically identified in their primary assessment. Non-serious patients may warrant an entire head to toe or may not warrant an entire head to toe. They fell and twisted their ankle. We're not going to do a head to toe on somebody when they can be like, my ankle really hurts. So we're just going to kind of do our secondary assessment on that ankle injury. Sometimes patients do not appear to be serious, but later conditions can deteriorate. So when in doubt, we're going to treat these patients as serious if we're not really sure what's going on with them. So indications that a serious condition may include or may be present if they have a significant mechanism of injury. So adults, if they fell down from stairs, landed on their head, having some neck pain, they have a major cut, something like that. They could have altered mental status, so they're not really sure what's going on. They're not all with it. Pale, cool, sweaty skin, because normally we don't just sit there with pale, cool, sweaty skin. Something's going on internally. If they're having chest pain or discomfort, if they're in any kind of severe pain, a lot of times, sometimes it's abdominal pain, or if they have an elevated pulse and respiratory rate, which is kind of the start of the signs and symptoms for shock, which we'll talk about when we get to trauma. Your pulse rate goes up, your respiratory rate goes up, but your blood pressure is pretty good. So those are kind of the initial stages of shock. So when it comes down into what kind of patient do I have, we have seriously ill or injured, non-seriously ill or injured, then we have medical and trauma. So medical versus trauma assessments are a little bit different. For medical assessments, something internal is going on that we can't observe, we can't palpate maybe. So we're going to be asking them a bunch of questions. So we're going to use the mnemonics sample and OPQRST to assist us in remembering which questions to ask these patients. So again, remember, sample is our signs and symptoms. A is allergies. M is medications. P is past medical history. L is our last oral intake. And E is events leading up to the illness or why they called us. Throwing in OPQRST, and I'll show you why this is important on those sheets when we're done with this chapter. O is onset. So when did it start? P is provocation. Is there pain present anywhere else? Does it go anywhere else? Q is the quality of the pain. Can they describe it? Is it dull, achy? Is it sharp and stabby? R is radiate. Does it go any other region? Are they grabbing their chest and it's going out into their arm or up into their jaw? Are they having back pain? Is it going anywhere else? Is it radiating? S is severity. That's our 1 to 10 scale. 1 being you're not in any pain, 10 being the worst pain of your life, where you fit. And we can tailor that question as well. 1 being it's not hard to breathe, 10 being it's really hard to breathe. Where are you at with that? So we can kind of tailor that severity question a little bit. And then T is our time. When did it begin? And how long has it been present? What's going on? So again, we have onset, provocations, anything that makes it better or worse, quality, what does it feel like, radiation, does it go anywhere, severity, that's our 1 to 10 scale, and time, how long has it been going on, when did it begin. And I have some handouts for these two that breaks these down as well for you guys that I gave you. Trauma is a little bit different. That's more of a hands-on assessment for people doing a head to toe, which often reveals evidence of injury through us observing and palpating. So look and listening and feeling. Trauma patients also might have a suspected spine injury that require manual stabilization of the head and neck. So if they do have anything going on with their head, their neck, their back, we're going to manually stabilize their head and then eventually put a C-collar and backboard them. So when we get into the head to toe for trauma patients, just like it says, we're going to start at the head. So this is our head to toe. So we're going to start at the head and we're going to look, we're going to palpate, observe, and assess the entire head. We're looking for dots, right? Deformities. What's O? Open injuries. T is tenderness. S is swelling. So using palpation and observation, we want to assess the entire head, including the skull and the bones of the face and the jaw, including the lower jaw. We're going to look for asymmetry and discharge from the nose and from the ears. That would be the cerebral spinal fluid. So we want to make sure we're looking for that, or blood. coming from the nose or the ears. We're going to check the mouth for secretions and clear it with suction if we need to. Look for broken teeth, anything like that. So checking the whole head, looking for dots. We're going to move to the neck. We're going to palpate the back of the neck, and we're going to look at the front of the neck right here. We're looking again for the dots. We're going to palpate the front and back. Some of the older folks and some folks do have a stoma, which would be there as well. But if we suspect a spine injury, we're going to take manual stabilization just like this person here. But we are looking for kind of feeling the back of the neck, just making sure the C-spine is good. The front of the neck, we're looking for jugular vein distension on the side. We're looking for tracheal deviation or shifting of the trachea, which can mean stuff going on in the chest area with that. Just looking at those two things. We're going to palpate the chest. I start kind of with the shoulders and then going into the chest, making sure those ribs are in place. Get good chest rise and fall during a breath. Good movement should be noticeable, adequate, and symmetrical. We can auscultate the chest, listen to lung sounds here and up in here, making sure that they're getting that good air movement. So palpating the chest, feeling for signs of injury, like crepitus is like that bone-on-bone grating. So they've gotten something broken in there. Looking for any contusions, which are bruises, any penetrating trauma that you see in there, because if there's stuff going on in the chest, that can affect their airway. So then we're going to move into the abdominal area. And with this one, remember the belly button is the middle of our quadrants. So we're going to palpate all 4 quadrants, right upper, left upper, right lower, and left lower. We want to palpate each of the 4 quadrants. Belly button's the middle. We're looking again for dots, as well as feeling for rigidity or masses, stuff like that. We can roll them over and look at their back, just to making sure from their C-spine area, back of their head, all the way down to their buttocks, just making sure that their back is good. Anything else that you see on the back that are dots. We can do this last if we want to as well. Some people choose to do it here. Just make it the same every time for a patient once you start doing it. We can then roll them onto a backboard if C-spine is necessary. We're going to go to their pelvis, and we're going to kind of gently push down, pull up on their hip area, looking for deformities, crepitus, our dots mnemonic. Looking also at the genital area to see if they've had any incontinence, bowel movement, or loss of bladder. Priapism, it's a male erection. Those can all indicate that they've been unresponsive or maybe have a head injury. We're going to work our way down each extremity. The foot, work your way down the legs, feeling all the way down. You're going to check pulses, check a cap refill at the end. Can they wiggle their toes or some kind of sensation? Run your pen up their foot. Can they feel that? Do the same thing on the other leg all the way down, checking their pulse, cap refill on their toes. Can they wiggle? And then you're going to go back and also do their arms, working your way all the way down their arms, checking that radial pulse. Can they wiggle their fingers or grab your finger? Can they feel where you're touching? So all 4 extremities we're going to do. When we do this head to toe, there's certain factors that can make our assessment a little bit more difficult or sometimes inaccurate. Confusion or excitement. We want to remain focused and stay calm. Fear or denial. Some patients will deny pain or illness because they fear of going to the hospital, or they don't want to ride in the ambulance. They don't want other people to worry about them. Altered mental status. Some patients may answer your questions inappropriately or not answer your questions at all. So this is another technique that we can rely on to figure out what's going on with our patients. Disabilities. For patients with cognitive disabilities or hearing loss, we want to enlist the help of family members and caregivers to get some information from them as well. Heavy clothing. We can remove what is necessary to assess the patient adequately. We can replace it then if we need to, or cover them with a blanket to keep them warm. Distracting injuries. Don't allow yourself to be distracted by a really cool injury, especially if it's not life-threatening. Age. Children and the elderly may respond differently to conditions like pain and have a physical difference in vital signs than average adults. So a lot of times we'll talk about this when we get to pediatrics, but A lot of times when it comes to children, instead of head to toe, we're going to flip it and do a toe to head on them so they get more comfortable with it and explain the process to them. So that's our head to toe. Vital signs, we talked about these. So major vital signs that we have, respiratory rate, pulse, skin color, temp, condition, pupil sizes. We can get our pulse oximetry out and check their pulse ox. And then we get into a reassessment. So baseline vital signs are our first set of vital signs that we take on somebody. And anything we take after that, this is what's going to start a trend to see how the patient is doing. Are they getting better? Are they getting worse? Are they staying the same? So 2 or more sets kind of allow us to identify that trend in our patient's condition. So vital signs should be obtained at certain times. So when we do reassessment, we either have stable patients or unstable patients. So if we have a stable patient, they're doing good, we're just kind of watching them, monitoring them. We can take their vital signs about every 15 minutes. If we have somebody that is unstable, we're not really sure what's going on with them, we're thinking that they need to get to the hospital, we're going to take their vital signs and do reassessment every 5 minutes. So when it comes to reassessment, we're going to reassess the primary assessment. So again, looking at our airway, our breathing, circulation, talking about that chief complaint again. We're going to reassess the vital signs. So all of the pulse, the respiratory rate, the blood pressure, the pulse ox. We can reassess all of that. The patient complaint that they have, has it changed at all? And then any interventions that we've done. So an intervention is something that we've done to somebody. So we put oxygen on somebody. That's an intervention that we have to reassess and check on. Is it still needed at that level? Can we reduce it? Do we need to bump it up? Do we still have oxygen running to the tank? Stuff like that. So anything that we've done to our patient, we put a bandage on. Is that bandage still working? That's an intervention. We need to reassess that. So again, unstable patients, we reassess every 5 minutes, and we're going to reassess all of this stuff every 5 minutes. Just keep working on them. And then if we have a stable patient, we can reassess every 15 minutes. All the stuff that we've done, primary assessment, vital signs, their complaint, interventions that we've done. The big picture, this is for trauma patients. So let me make this a little bit bigger. So determining patient priorities based on the mechanism of injury, the complaint, and our primary assessment. We're going to expose the patient as appropriate. I tell my students trauma naked. So if it's a legit trauma patient, we cut all their clothes off down to their underwear so we can see what's going on with them. And when appropriate, as appropriate is it's negative 40 out. We're not going to do it on the side of the road, right? They're just going to get hypothermic and frostbite. So making sure we're doing this at the appropriate times. Performing our head to toe exam, performing our vital signs, getting a good history. If the patient can't answer our questions, hopefully some bystanders can or family members that are around. And then monitoring the patient, continuing that reassessment until the ambulance arrives is our last step. For medical patients, doing our assessment based on their chief complaint or what they tell us is wrong, that's their chief complaint. Obtaining a history using our sample and OPQRST mnemonics, checking medications, that's part of our sample. Have they taken medications before we've gotten there? Things that the ambulance is going to want to know when they arrive on scene. Checking vital signs, maintaining positive demeanor, getting down on their level as well. We'll talk about that a little bit too. Performing a physical exam as appropriate. So maybe they're having chest pain. We're not going to do a head to toe on these patients. We're going to do a more physical assessment of their chest area, asking more questions about that. And then examining their complaint on the specific area, which is kind of what would be our head to toe for medical. And then performing any ongoing rechecks that we have to do in reassessments. Again, if they're stable, every 15 minutes. If they're unstable, every 5 minutes, we're doing this. And sometimes more if they're really unstable. So primary assessment, I'll bring this up so you guys can see this. Primary assessment focuses on immediate life threats, while secondary assessment focuses on everything else. Our history, complaints, how we're going to do our assessment, asking questions, doing our head to toe, all of that fun stuff is secondary. The trauma patient usually will benefit most from the assessment findings revealed in our head to toe exam. So secondary assessment for medical is lots of questions, trying to figure out what's going on. And secondary assessment for trauma is a head-to-toe exam. After assessing the head using the DOTS mnemonic, we should next observe the neck, right? We're going to go head, neck, chest, abdomen, back if you want to, pelvis, extremities. Looking for dots, deformities, open injuries, tenderness, and swelling, and anything else that you're observing. These are some of the skills that I have my other students typically do. So, but we'll talk about sample OPQRST here. So I'm going to stop sharing. Any questions so far on that one? No? Okay. All right, let me see if I can share. Let's start with vital signs. So I have given you guys this, and this just kind of breaks down the different vital signs and how to do them, why we do them. So respirations, assessing respirations, examines the patient's effort in breathing. This kind of counts you down on how to do it, and then some sounds you're going to hear, and some other information about the number, the quality. Pulse, that's that palpable pressure that's created when the heart ejects blood into the arteries again. Confirms a heartbeat, at least minimal pressure in the cardiovascular system. So talking about the areas to do that, how to do that. Our skin, assessing our color, our temp, our condition, and then talking about capillary refill time once again. We don't just do this in kids, we also do it in adults as well. Usually we use their fingernail. Pulse oximetry, again, that measures the amount of oxygen carried in the red blood cells or hemoglobin, and is an accurate way to assess the level of oxygenation that our patient has. And certain readings, we want to put oxygen on them. And then blood pressure, this breaks it down by talking about systolic again, which is our top number. That's when we have the contraction of the heart, so it's a little bit more pressure in the arteries. And our diastolic, which is when the heart is relaxing and refilling, which is why it's a little bit less. It's our bottom number. And then all the numbers on here for you. And then the two methods of doing it. We can auscultate the blood pressure, or we can do by palp or by feel. Again, with that one, remember, we're not going to get a bottom number. So it's going to be top number over P would be an example of that. And then pupils, normal pupils react to light by getting small and then get bigger. So we use what's called pearl. Pupils equal and reactive to light. And this is talking about how to assess that. And then I have the vital signs on here for you guys again, in case you've misplaced the other one. So that one is the vital sign one, just kind of breaks them down a little bit easier for you. Questions on that one? Hopefully those are helpful. All right. Next thing I'll show you is sample. So sample, again, this is a sheet that's going to break down what this mnemonic means. It's just a memory device used to gather patient history information to not diagnose, but have that index of suspicion on what's going on with our patients. So again, S are signs and symptoms. A is allergies. M is medications. P is past history, medical history. L, last ins, last outs. Because I also like to know what's coming out of them. They pooped. Okay, what color is it? Like, when was the last time you pooped? So maybe they have a bowel obstruction, something like that. And then E is our events leading up to the situation. So this one is just going to break down each of these, and it has some questions in there that you can ask people. So you're not up there going, hey, what's your signs and symptoms? This breaks it down so it's a little nicer for you to ask questions. Any allergies? So you're allergic to any medications? Do you have any other allergies that we should know about? Et cetera, et cetera. Medications, what medications do you take? Have they taken any before we've gotten there? So this is just breaking down each of these and giving you guys some questions to ask. Questions on sample. Everybody's got that one down, right? Yeah. Yep. See some heads shaking. Yeah, I got it down. All right. The next one is, I'm going to bring this up and go. Nope, not that one. Not yet. Trying to find my PDFs. Here we go. Found it. So this is our OPQRST. So these are, our other tool for asking questions. So instead of walking up to somebody and being like, "What's your onset?" This is our mnemonic that's going to help us remember what kind of questions to ask. So when it comes to onset, the word onset should trigger questions regarding what the patient was doing prior to or during the onset of a specific symptom or their chief complaint. I'm having chest pain. Okay. Well, what were you doing when those symptoms started? Was it sudden? Was it gradual? Things that are going to be beneficial to know. So onset is just asking those questions. Provoke, again, you're not going to walk up to your patient and be like, "What provokes you?" So this is going to trigger symptoms. What makes it better? What makes it worse? Is there anything that makes your symptoms better or relieves them, makes them go away? Is there anything that makes them worse? Quality, again, that's our how does it feel to the patient? So can you describe the symptom or the pain or discomfort that you're having? What does it feel like? Is it sharp? Is it dull? Is it steady? Does it come and go? Has it changed? Can you point at it? Is it so is it like a general, like you're just not feeling well? So what's the quality of it? R is radiate or region. Um, Trying to figure out the location of the symptom. So can you point at it with your finger where it hurts most? Does it radiate or move anywhere else? Severity, that's our 0 to 10 scale, and we can use that for certain other things as well. So how would you rate your level of discomfort right now? We can use the same scale like when it first began. Maybe we put them on oxygen. We can do that again. Is it making it better? And then time, this is kind of when did the symptoms begin? So when did the symptoms first begin? Have you ever experienced these symptoms before? If so, when? What did it feel like last time? So just information we can gather from people to kind of figure out what's going on. And I'll show you in a second why that's important. Okay, I'm going to stop share. Questions on OPQRST. Are we making flashcards? No, flashcards. AVPU, sample, OPQRST, Pearl, dots, flashcards. Okay, so the other thing is I showed you guys this maybe last time, maybe I didn't. So these are some questions that we can ask people when it comes to certain areas. So if they're having a cardiac or something going on with their cardiovascular system, these are just block questions you can have in the back of your head of like, okay, they're having trouble breathing, laying down at night. We're going to talk about a lot of stuff coming up now. This is kind of like the last chapter of basic things, and then the next chapter, communication documentation, that we're going to start getting into respiratory emergencies, cardiac emergencies, and some of these questions will start coming up, and you'll see why this is beneficial. But this just breaks down the different categories in our medical assessment. Just so you guys can, in the back of your head, as we go through these chapters, have some questions in mind when we're asking people things. Pulmonary would be like asthma, respiratory, emphysema, COPD, things that are going on with the lungs. We have neurological. This is going to be like stroke patients, diabetics, altered mental status, seizures, traumatic brain injuries. We have our musculoskeletal system, so bones, sprains, MS. Integumentary, this is our skin, hives, rashes, stuff like that. We have our GIGU, gastrointestinal, abdominal pain, urinary tract infections. Those would be examples of that. We have reproductive, pregnancy. And then we have psychosocial, so certain special populations, mental disorders, suicidal ideation, stuff like that. So those are just breaking down each of the categories in the skill sheet that I showed you guys. So that'll be a good kind of base when we start moving into these next chapters that we have coming up. So let's see, I'm going to bring up. So remember these skill sheets, this is our medical. So we've been through this whole thing now. So we have our PPE, our scene size up, making sure the scene is safe, our mechanism of injury, nature of illness, requesting additional EMS necessary, consider stabilizing the C-spine if they've, they think if you think they've hit their head, neck, and back, anything like that. We have our AVPU, so determining that level of response or level of consciousness. We have our alert, voice, pain, unresponsive. We get into what's their chief complaint? What are they telling you what's wrong is their chief complaint? You're looking for any apparent life threats that we need to fix right away. We move down into airway and breathing. We're going to assess their airway and breathing, making sure they have adequate ventilation, so good rate, good quality. Do we need to start oxygen on them, and what would we do? Non-rebreather, nasal cannula, bag valve mask. We're going to assess their circulation, so assessing, controlling any major bleeding that you see, checking a pulse, rate and quality, and the regularity of that pulse. We're going to assess their skin, the color, temp, condition. Then we're going to make a transport decision. Then we're getting into history. So this is where it gets important. So this is our OPQRST is here, and the rest of our sample is here. So S in sample is our history, starting with OPQRST. So onset, provocations, quality, radiation, severity, and time. So this is our S for sample. Then we ask those questions, ask some follow-up questions that kind of are associated with those questions. Then we move down into the rest of our ample. So asking the allergies, are they on any medications, past pertinent history, last oral intake, events leading up to what's going on. After that, we ask a whole bunch of questions to them. We kind of have an idea of what's going on. So they're having some chest pain and difficulty breathing. Maybe it's a cardiac event, maybe it's gas, but either way, it pinpoints us down to cardiovascular and pulmonary. So then we can do our more focused secondary assessment on those body systems, the affected body part. If it was a stroke patient, we'd more focus on neurological. If it was something going on with their skin, we would do integumentary. If they're having abdominal pain, we'd go more GIGU. And those questions that I showed you guys come in play with the secondary assessment for medical. Kind of just has a backup of like, here's some questions already in my head that I can ask these patients. So after we get history, OPQRST, and sample, we then work our way down to, okay, what's being affected? We're gonna assess that body part that's being affected in here and ask more questions, maybe do a little assessment on them, like look, listen, feel in that area. And then we do our vital signs, our baseline vitals. So we've already done some vitals up here, yes, but we're going to do our baseline again here: blood pressure, pulse, and respiratory rate, pulse ox, that kind of thing. We have our field impression. This is what we're going to kind of state out loud of what's going on, and then we're going to check our interventions. We're going to see if this patient is stable or unstable. So when we're reassessing our patients, if they're unstable, every 5 minutes, we're doing at least our ABCs, checking our interventions, doing our vital signs, checking their chief complaint, and then stable patients every 15 minutes. So unstable 5, stable 15, and then when EMS arrives on scene, giving them that good kind of accurate of like what happened, what's going on, what did you do, what are the last set of vitals, et cetera, what are the interventions that you did. So that's where it gets into medical and why all this stuff is important. Trauma, very similar, right? So we have our PPE, making sure the scene is safe. This one's typically going to be a mechanism of injury for trauma. Additional resources needed. Consider C-spine. This is our AVPU. What's their chief complaint? Apparent life threats. We get into airway, breathing, and circulation are all different. So we have airway, open and assess it. Do we need to put an adjunct in, an oral airway or a nasal airway to keep the airway open? We're going to check their breathing. We're going to assess it. Are they breathing? What is their ventilation, their respiratory rate? Do we need to put oxygen on them? And then managing any injuries which may compromise the breathing. So looking at their chest, do they have any injuries, broken bones, broken ribs, a puncture wound in their chest that's going to affect then their airway and their breathing. We need to fix that to fix this. Then we get into circulation. We're going to check pulse, assess skin, color, temp, condition. We're going to assess for and control any major bleeding that we see that we maybe have missed. And we're going to initiate shock management, which is laying the patient down, covering them up with a blanket, putting on high flow oxygen, non-rebreather at 15, and packaging them up for immediate transport. This one, we're going to take vital signs right after that, or blood pressure, pulse, respiratory rate, pulse ox. We're going to get a sample history. If we can get that from the patient, great. Otherwise, we're going to ask bystanders. And if they don't know it, then we're kind of out of luck, but we get our sample history here. And our secondary assessment for trauma is our head to toe. So in the head, we're going to inspect and palpate the scalp, the ears, and what are we looking for? Dots, right? Deformities, open injuries, tenderness, and swelling. So we're going to inspect and palpate the scalp, the ears. We're going to assess the eyes for pearl, pupils equal and reactive to light. We're going to look at the mouth, the nose, and assess the facial area. We're going to look at the ears and nose for cerebral spinal fluid or blood coming out. We're going to look at the neck. We're going to check the position of the trachea. It's called tracheal deviation. If it's shifted to one side or the other, that can mean things. Check for jugular vein distension. That can mean some cardiac issues going on and some other issues if their neck veins are popping out. And we're going to palpate their cervical spine in the back of the neck. This is where I would then put a C-collar onto somebody if they need that. We're going to look at the chest. So inspecting the chest, we're going to palpate it and auscultate it. So we're going to look, listen, and feel. So looking at their chest, we're going to push down, pull up, making sure everything's stable, and listen to lung sounds. We're going to move to the abdomen or pelvis, inspect and palpate the abdomen, those 4 quadrants, right upper, right lower, left lower. Remember the belly button's the middle. We're going to push down and pull up on the pelvis area. Also looking for incontinence or other things in that area. Looking at the genital peritoneum as needed for priapism, things like that. You move to the lower extremities. So lower and upper extremities, we're going to assess for motor, sensory, and distal circulation. So we're going to work our way down each leg. Check a pedal pulse on their foot, checking, see if they can wiggle, check the cap refill. They know what toe you're grabbing, and same thing with the arms. So working your way down the arms. Can you check a radial pulse? Can they wiggle? Which finger am I grabbing? Checking a cap refill. And then we're going to roll them over and look at their back. You can do that if you want to after the abdominal or pelvis, but just whatever way you do it, make it systematic. People like to do it different ways. Just make it your way and make it systematic. But we're going to inspect and palpate their back all the way down to their butt. Put them on a backboard if you need to. And then we're going to manage secondary injuries and wounds as appropriate. So as we work our way through this, if we see something, we can bandage it along the way. And then if we see stuff and we don't bandage it, this is where when we're done with it, we should come back and bandage stuff or fix stuff as we see it. And then reassessment again, demonstrating how and when if they're stable or unstable, 5 minutes, 15 minutes. We're going to reassess the primary assessment. So we're reassessing all of this. We're reassessing their vital signs to start that trend. We're reassessing their complaints that they have, and then any interventions that we've done. So that's why these are kind of important, is all this stuff is a systematic way from head to toe and from good to bad and airway and all of that stuff is a good way to start. So questions so far on those chapters? No? Okay. All right. So let me get rid of a whole bunch of stuff that's on my screen here that you guys have access to already. All right, so last chapter for tonight, we're going to be talking about Communication and documentation. And I'm not sure what Jules has for you guys for documentation yet, or what you guys are going to be using, but I have a couple of things that I put on there that can assist you in writing some narratives and stuff like that. But so communication documentation, communicating with your patient, communicating patient information to other providers when first responders and ambulance get on scene, and then how to properly document. So as a first responder, you have to kind of effectively communicate with your patients in order to obtain important information, reassure them in times of crisis. You also have to be able to effectively communicate with other providers that are on scene in order to get that pertinent patient information passed along that goes with them. So additionally, using your communication skills is going to foster and maintain relationships between whatever agency you're working with and other agencies that you're going to be working with on scene. So once that patient is transferred to the hospital, other providers are going to use your documentation typically as well to determine the times when treatment was provided, vital signs that you have taken, and some of your information. So it is also part of a quality improvement program, quality assurance, that they can use as well. So communicating with our patients. So considering some of the following: noise. We want to minimize noise. So take steps to either reduce or eliminate noise or move patients into a quieter spot, more appropriate environment. If they have their radio blaring or their TV blaring, we can shut that off or have a family member shut that off so we can communicate with our patient effectively. Lighting, adequate lighting allows us to see one another, see our patients. And it's different if you're out at a campsite at 3 o'clock in the morning and you have your headlamp going. But if you're in their home and we can turn the light on so the patient can see you, we can see the patient, especially if it's at night, that would be good. Privacy, if the patient appears uncomfortable answering personal questions in the presence of others, we can have them kind of leave the room and distance themselves so we can get the accurate information we need to from that patient. We want to get on that patient's level, be aware of your positioning and your stance when we're talking to patients. We're not going to stand over them and be like, what's wrong with you, right? We want to get down, especially if they're sitting in a chair, in a wheelchair, get down on their level. I always tell people to squat because I've knelt in things that I don't really know what they are at patients' homes, but you can feel free to kneel. I typically squat now in front of the patient, so none of my clothing is on their carpet because things get squishy. But so get on the patient's level, or at least bend over and make eye contact with them and have a chat. Personal space. This is an area of about 3 feet around us. When others come into that area, sometimes it makes people uncomfortable. So making sure you're aware of that we're not intruding on their personal space. And then minimizing interruptions. Family members talking over you, bystanders, pets, radios, cell phones going off, that kind of thing. So turning things down, having that minimum interruption, giving them time to talk to you in the space and to do that. We want to use some techniques. So active listening, give your patient your full attention, making eye contact with them, acknowledging what they're telling you when they speak. There's some barriers to communication. So we've kind of been discussing some of those through communication. So avoiding them to effectively communicate with our patient. So some of those barriers, again, like turning the lights on, turning the noise off, that type of thing. Procedures, avoid assessing the patient while we're talking to them. We're going to balance our assessment time with listening to the patient. We want to make sure that we're giving them our attention as well as we're assessing. So sometimes if we have a partner, we'll have somebody assess them while we're asking them questions. Body language, often referred to as the nonverbal communication, our stance, our tone of our voice, how we look to that patient. That tells the patient whether or not we're interested in what they're saying and what their condition is. So again, don't stand over them and act all tough. Just get down on their level, make eye contact with them, and have a conversation with them to see what's going on. So when questioning patients, we try to start with open-ended questions, prompting the patient to answer with complete thoughts, not just a yes or no answer. So if we ask somebody, please tell me what made you call the ambulance tonight or call 911, that's going to be an open-ended conversation on them telling you what's going on. And then from there, we're going to get their chief complaint. Close-ended questions prompt the patient yes or no. So we can use these like, are you having chest pain? No. Do you feel pain anywhere else? Yes. Where? So there are reasons to use open-ended questions and closed-ended questions. Some pitfalls with this, to adequate questioning, asking the patient multiple questions at once, give them time to answer. Talking too much, interrupting the patient while they're answering, trying not to be judgmental. We don't want to appear judgmental towards the patient or the family. Asking leading questions, giving unwarranted advice to the patient, providing false assurance, right? We're never going to say you're going to be okay. It's, we're doing the best that we can in the situation, stuff like that. So different interview techniques, open-ended questions we kind of open with, certain times to use close-ended questions, and then just don't bombard your patient, especially if it's an older patient and they're trying to like answer all these questions at once. They're going to forget stuff. So just take your time and ask one question at a time. They can answer, give them some extra time sometimes. All right, so communicating patient information to others, information typically shared with other providers as care is transferred, as we transfer that care is usually going to include the patient's condition, their age, their sex, their chief complaint, history of the present illness, how the patient was found, our sample essentially, medical history, the vital signs, the physical findings that we have, and the care that we've given so far. General rules for using radios, we'll get to that, but speaking clearly, we don't use patients' names over the radio. Yeah, keep it very basic over the radio. So when it comes to radio communication, and I don't know if you guys will be carrying these, probably not, but if you get on a service, you would be. We use portable radios. These are two-way radios that can easily be carried on a belt. There's mobile radios. These are the ones that are mounted in a vehicle. I always say portable, like you can carry them with you. Mobile is in an automobile, so they're kind of stationed in, like this one on the screen. And then you have your base station radios, which these are the fixed locations, like dispatch centers and hospitals have the base station ones. When we're talking on the radio, some general rules to follow. We want to speak slowly and clearly, normal volume. Don't scream into the mic. Hold it about 4 inches from your mouth. Too close, it's going to kind of garble. Too far away, it can kind of reduce the volume and the noise behind you can be picked up. Only speak when necessary. We're not going to try to tie up that frequency with unnecessary traffic. Listen when you turn that radio on, before you key it to talk. Listen for other radio traffic that might be transmitting. There might be something more important going on than what you're doing. We're not going to use names or transmit confidential information over the radio, and we'll talk about HIPAA a little bit more too. Speak professionally, avoid using slang, names, humor. Everybody can hear you out in scanner land when you're on these things. Make sure your batteries are charged up, and then follow local protocols when it comes to procedures regarding radio usage. When communicating with our patients, sometimes we have challenged patients. So they have a little bit more difficulty communicating. So the difficulty may stem from a problem with hearing or vision, from a condition like Alzheimer's, autism, other cognitive impairments. So when communicating with patients, we want to take our time, determine the extent of the patient's difficulty from the family or patient themselves. Is this normal for them? Like, is this their baseline or is this different? Why are, like if they're having a stroke, is this the new onset of symptoms or was this like what they were like before you called 911? Ask the family how to communicate with the patient. They're going to know how to best communicate with that patient. Don't assume reduced intelligence because they have difficulty understanding you. And we're not going to shout at patients. We're just going to slowly work our way through it. If we have to write some stuff down, I've had to do that in the past, and they can answer. Some situations we might run into, deafness. Most individuals who are deaf rely on reading lips, so ensure adequate lighting so the patient can see you. Look directly at the patient. Do not cover up your mouth while you're speaking. Speak at a normal volume and speed. We can also write down questions or ask family members to translate, especially if it's sign language. Patients with deafness may not speak clearly, so don't assume that this means that they have a reduced intelligence. They talk differently. Blindness. Blind patients usually get around and take care of themselves without any problem. Guide them or explain their surroundings if necessary. Talk to them a little bit more than you would anybody else because they are not seeing what you're doing. Also with that, if you're moving stuff around their house, be careful with that. Try to replace it back where it was because they have that layout down. We don't want them to start tripping over stuff when they get home. Mental impairment, for some patients, we may need to rely on family members or other healthcare providers to tell us about the patient. So asking family members or bystanders or caregivers. When the patient has difficulty communicating with us, ask if that's their current condition. Again, is that normal for the patient? Otherwise, we can assume that that patient has an altered mental status when it's not their normal. Something new is happening now. All right, documentation. We use what's called pre-hospital care reports that document pertinent information about a call, and that is a valuable kind of continuing the chain of healthcare. Typical pre-hospital care reports usually have some run data, patient data, and narrative that details patient care that was given. When the patient refuses care, we're going to document that. There are some steps warranted for that, for maybe us to talk them into being transported, that type of thing. But as a first responder, we're more than likely to be on a scene of an emergency. So our observations, patient assessment findings, and patient care are going to be vital, and they have to be documented. Otherwise, they didn't happen. So when it comes to documentation, we use what's called a pre-hospital care report, or a PCR. Some people call it a patient care report. The documentation is most commonly in the form of that. It's a document that it's usually provided by your agency or region or state EMS office. Some of them are handwritten, some of them are computer-based, depending on what your service uses. The PCRs have a lot of functions. The most common is transfer of care from one provider to the other. So this is part of a process called continuity of care. Assessment and care that we provide is seamlessly transferred to the responding EMS personnel, eventually the hospital staff. So these also serve as an administrative purpose and identify which responders were on scene, provide information for quality improvement, stuff like that. So some elements that are involved, I guess some components that are involved with the pre-hospital care report or patient care report. You have run data. This includes administrative information like the agency name, names of the crew members, the run times when we go en route, when we're on scene, back in service. The patient data, this includes information about the patient gained during the assessment, like our physical findings, our vital signs, patient history, mechanism of injury, observations at the scene. And then we write a narrative. There's a space that's provided for us to write additional details about the call or to clarify information that couldn't be clarified in other sections. Disposition of the patient at the time of the transfer of care, what we all did, pertinent findings, that type of thing. Patient refusals. When a patient refuses care and transport, we want to attempt to convince that patient to accept care and transport. If we cannot, we can get a refusal of care. We want to document this pretty well. So some things that we can document. We advise the patient that further care and transport is warranted. You advised of the risk of refusing, including worsening of their condition. We took steps to convince that patient to accept the care. Advising the patient or family to call back if needed. We encourage the patient to seek help elsewhere. Go to the clinic, have one of their family members bring them in. And then the last one is when we do this, if it is a refusal, and we'll talk about reasons why people can refuse coming up eventually here, but it's highly recommended that us as EMS personnel who arrive on scene try to attempt to get them to accept the care and transport. And then when we're documenting the refusal, to either have a family member and the patient or law enforcement, somebody other than your partner on scene to kind of sign off on that refusal. So the narrative part of this is a legal document that can be subpoenaed into court proceedings. So our documentation has to be relevant, it has to be accurate, objective. Documentation includes factual or clearly observable details like our vital signs, our wounds, the mechanism of injury. Our subjective documentation with this must sometimes be noted. So using quotation marks to indicate relevant information that the patient tells us. Patient stated this. Patient said something to the effect of this. So anyone who reads the patient care report or pre-hospital care report kind of knows where the information came from. It came from the patient. And in some cases, a patient or someone on scene may make a controversial statement or comment that's relevant to a legal issue. In those cases, we can document the statement in the narrative by writing the patient states, something like that. Special reporting situations. So as a first responder, we are required by law to report certain findings. We need to report abuse, we need to report assaults, gunshot wounds, sexual assault, and infectious diseases. We can document our findings in these situations as you would any other. Since it's highly likely that your patient care report or pre-hospital care report will be viewed by others and be introduced into court as evidence, we want to document thoroughly, accurately, and objectively. We want to avoid subjective statements in your report unless it's necessary. So examples of subjective statements would be stuff like the patient was beaten up, patient's not cared for in the environment. They don't want your opinion in on it, just the facts. Okay, so the type of communication used to help a patient and calmly reassure them is referred to as, really talk a whole lot about this, but this is therapeutic communication. We can use open-ended questions and closed-ended questions, but this would be therapeutic communication. When starting a patient interview, what type of questions is best? Open-ended. Hey, my name is Alyssa. I'm with Ely Ambulance. What's going on today? They tell me, now I got my chief complaint. I know what's going on. I can use closed-ended questions like, are you having chest pain? Yes. Okay, where is it at? Point at it to me. What does it feel like? And then we can get into the rest of our questions with that. Patients with hearing difficulties will often be able to communicate by seeing your mouth, right, as you speak. So don't cover up your mouth, talk just in your normal tone of voice at a normal speed. All right, I'm going to stop share. Questions so far on that? Everybody awake? Okay. Heads went that way, heads went this way. Okay, we're good. All right, so the last thing that I put in the email to you all was under communication and documentation, the SOAP and chart formatting. And these are just ways that you can write your narrative. So I'm going to share my screen quick so we can go over that and then we'll be kind of wrapped up here. So this is our mnemonics chart for doing our narratives. So just examples for you guys to get started if you are going out with a service and writing narratives. So some people use the chart and some people use the SOAP method. So chart is complaint, and this just walks you through like examples of what you would put in under these. So C would be complaint. So yeah, the patient is 50-year-old male complaining of substernal chest pain, nausea. The complaint is described as heavy pressure, mid-sternum, and radiation to the left shoulder. We get into the history. So just talks about all the history of the patient, which is kind of your sample, OPQRST. A is assessment. What did you all do? And writing all your assessment down, going through, this is some of your physical exam. So your vital signs, your impression, your head to toe, how everything looked. And then R is treatment. What did you give them? What did you find? What interventions did you do? And then T is transport. What's the transport method? How you got them there, where you went, what you did. You called in ahead, that type of stuff. So some people use this method. Some people use what's called SOAP. So SOAP format documentation. S means subjective. So you were dispatched to this. This is what you saw on scene. Objective. So your initial, this is your head to toe information, everything that you objectively saw. And then A is our assessment, field impression, like what's going on. And then P is our plan. So what did we do? Like our transport plan, our assessment plan. What did we all do for that patient would be the P part of that. So that is our SOAP and chart format. Kind of just examples for you guys to use to start out with if you're needing that for your narrative. Okay, so far so good. All right, so we've been through chapter 13. The next chapter's coming up. So next Sunday, you guys are on your own because Jim and I are going to be in New York. So have fun. You guys are going to be doing the NIMS 100. So I give you some hours to do that. You can do 700 if you want to. That's coming in August. I know Jules wanted those certs from you guys. If you've already done them, you have a free week next week if you've already turned those into her. But the IS 100, tomorrow morning at 8, you'll get another email from me with how to get into that and how to do it with a link like I normally do. And then the following week, we will get into chapters 13 or chapters 14, which is cardiac and respiratory emergencies. 15 is altered mental status, and 16 is medical emergencies. So we're talking about some medical issues that people might run into. And then the week after that, we'll get into trauma. So, questions? No? Again, you guys can always email me. I will pause the recording on this or stop the recording on this.